Healthcare reform is a term used every day in America. It is frequently changing in order to attempt to provide care to all individuals. Healthcare reform has vastly changed from the past to the present, however, many changes are still needed. So, what is healthcare reform and why do we need it? Healthcare reform generally attempts to broaden the population that receives healthcare coverage, expand the array of healthcare providers, improve access to healthcare specialists, improve the quality of healthcare, and finally decrease the cost of healthcare. In reality, healthcare reform has been around for centuries and has been the cause of many changes to our healthcare system. The following is a short list of important healthcare reforms through history. In 1854, the Bill for the Benefit of Indigent Insane was vetoed by President Franklin Pierce, who reasoned that the federal government should not commit itself to social welfare. Post-Civil War, first involvement of federal government was the short-lived establishment of 40 hospitals in the South to provide national medical care. 1912, organized medicine opposition to universal health care was standard. In 1933, Franklin D. Roosevelt included publicly funded healthcare programs with Social Security legislation. 1951, the Internal Revenue Service ruled group premiums paid by employer in a tax-deductible business expense. And July 30th, 1965, President Lyndon B. Johnson signed into law Medicare and Medicaid. In the 1970s, there were 5 proposals for national health insurance that failed. In 1985, COBRA, Consolidated Omnibus Budget Reconciliation Act, amended the Employment Retirement Income Security Act of 1974 to give some employees the ability to continue health insurance coverage after leaving employment. In 2000, President George W. Bush expanded Medicare coverage to include prescription drugs. And in 2010, President Barack Obama signed into law the Affordable Care Act. There are 2 kinds of reform pertaining to the Affordable Care Act: economic and health care. Limbigler and Lammer explain how both affected the passage of Patient Protection and Affordable Care Act. They commented that healthcare reform has been successful not in spite of, but rather because of, the economic crisis of 2008. That allowed President Obama to use a strategic frame focusing on costs and economic problems. An interesting change was noted in regard to the focus of President Obama before and after the passage of PPACA. Economics, the cost of healthcare, and the recession was the focus before signing into law. Afterwards, a rights approach to healthcare mandates universality of coverage, while also having a provision of equitable financing became the emphasis. According to Limbigler and Lammer, it's also stated that the PPACA did not reform healthcare insofar as making the U.S. system into a single-payer universal system, but rather worked to continue a similar market system already in existence. According to Young and Croft, stakeholders are the people who have a vested interest in the situation. The American public is the first stakeholder by reason that if no one needed health care, there would be no reform needed. Second are the employers who pay for a high amount of the costs and have a role in determining the prices. They also have a lot of power in politics. Next are the providers. They are the core of the industry and provide the services. Then there are the facilities where the healthcare is performed. Federal and state governments are the entities that not only pay for healthcare, but they also control regulations and collect taxes for funds to operate the system. In the current marketplace, there may be annual changes to healthcare plans causing confusion for the individual that is attempting to purchase the plan. This could cause the individual to lose current insurance plans or have a decrease in coverage if they are no longer able to afford their current plan. According to McKillop et al., Individuals facing re-enrollment decisions for plans that continued the following year were also affected by rising premiums. Over half of silver plans that had been the lowest cost initially were no longer the cheapest option in the subsequent year. This places an unfair burden on someone that is attempting to purchase healthcare insurance from the marketplace. With this burden, the consumer also needs to have a better knowledge of the plan's limitations and cost. Many consumers lack the knowledge required to make these decisions. According to Fitzgerald, Bias, and Gurley-Calves, about 12% of U.S. adults have proficient health literacy, and about 38% have only basic or below basic health literacy. When consumers have more literacy, they can make smarter decisions within the marketplace. McKillop et al. Suggests that providing enrollees with tailored educational materials pertaining to their plan is one low-cost way to decrease the burden of having to choose the best plan each year. When consumers are more educated on health, they may make better decisions about their insurance coverage. McKillop et al. Also suggests that future healthcare policy should aim to stabilize the marketplace by making sure the mandate to purchase health insurance is enforced, by decreasing the burden to consumers of having to consider re-enrollment every year. Example, by providing targeted educational materials, and by changing the current subsidy design to encourage greater enrollment of younger, healthier adults. These changes would benefit the consumers of healthcare and ease the decision-making of the future marketplace. Access to healthcare is also an important part of healthcare reform. Currently, the ACA does not provide universal coverage, according to Morrow and Joseph. Many individuals are left without or with less insurance coverage than they previously had. Morrow and Joseph note that individuals covered via the health exchanges still will not receive services such as vision and dental that are not considered essential health benefits. More importantly, an estimated 23 million people, about 8% of the non-elderly population, could remain uninsured due to becoming income ineligible for subsidized coverage, encountering enrollment barriers, or experiencing lapses explicitly excluded from the ACA. Immigrants are affected by this, and unlike U.S. citizens and most legal immigrants, they cannot use their own money to purchase private insurance via the exchange. Their only options are to pay for services out of pocket or self-medicate, according to Morrow and Joseph. The unauthorized immigrants that cannot get access to the market are now in the spotlight because of their lack of insurance. Perhaps if they chose to seek care, it would be quite obvious that they might be undocumented due to their lack of insurance and could also put them at risk for biased treatment. San Francisco has allowed for the undocumented to receive healthcare access. Income and local residency rather than documentation status were the main criteria for HSF eligibility and inclusion, according to Morrow and Joseph. By doing so, San Francisco was able to significantly drop the insurance rate. When the documentation of a patient is no longer relevant, it may also improve the care they receive from a physician because the physician is no longer concerned about what is and is not covered under their current plan. Morrow and Joseph also suggests that revising the 1996 Immigration and Welfare Reform policies that make them ineligible for ACA could grant them greater access, as well as comprehensive federal immigration reform could adjust their documentation status, which would also make them ACA eligible. Reforming the immigration laws could provide more access to immigrants and allow them to have healthier lives.